Thank you, Anne, and good morning, everybody, and a very big welcome to you on this, the first session of the this year's International Disability Summer School on this lovely day. We talk a lot about weather in Ireland because we rarely get days like this, so cherish it. We do. My name is Mary Keyes, and I will be chairing this session. I'm delighted to introduce the first speaker, the UN Special Rapporteur on the Right to Physical and Mental Health, Dainius Puras. Who comes from Lithuania, is a doctor and is a professor of child and adolescent psychiatry at the University of Vilnius. He is a human rights advocate and has been actively involved in research and in the process of changing public health policies and services, especially concerning children. He was a member of the UN Committee on the Rights of the Child and has worked as an independent expert and consultant to many governments, NGOs and UN agencies in the field of the right to health. So he has an amazing CV. Many of you will be aware of the recent report of the UN Special Rapporteur on Physical and Mental Health, the report on the right to enjoyment of the highest attainable standard of physical and mental health. And this report is unique because, for me, it exposes and highlights all of the elephants that we ever talk about and puts them all into one place. It exposes all the concerning issues. And it stands to make a very important contribution to the discussion on the emergence of mental health as a global priority. In this report, we are reminded that we all need an environment that supports our mental health. We all need that. And that we are all potential users of mental health services. And I think that's a really important point. I had the privilege of hearing Dainius speak in 2005 at the University of Leeds, where myself and a colleague were accompanying a group of students to an occasion of learning on disability studies. Today, Dainius is going to speak to us about the core challenges to the realisation of the right to mental health, considering the right to health generally and addressing the specific obstacles to the realisation of the right to mental health, and in particular the difficulties for women in this area. There will then be time for questions, so as we go along you can be thinking about that. Could you all turn off your mobile phones, the usual old question or suggestion, and without further ado, please give a very big welcome to the UN Special Rapporteur on the Right to Physical and Mental Health, Dainius Puras.
Good morning. It is a great pleasure for me and honor to speak to you. I will first tell some words about my mandate, then my background, and then will describe main messages of my last report, which was now mentioned. My mandate belongs to the mechanism of special procedures of United Nations. It's one of mandates, right to health. There are many other mandates, thematic and country. We are now a group of about 80 mandate holders, because there are also some working groups in special procedures. Next week we meet in Geneva for our annual meeting, and we will discuss general situation with human rights in the world, and I will touch upon a little bit on this as well. This is a very interesting design, very creative. Special rapporteurs are actually not UN. They are appointed by UN, but they are independent from UN. They are not salaried, they do not work, they are not staff of UN, so the biggest asset is independence. And we just, when we travel to mandated activities, like to report to New York and Geneva, and on country missions, then we are covered our expenses. This mandate was established, as you see, 15 years ago. I had very good two predecessors, Paul Hunt, who is now in University of Essex, and Anand Grover, lawyer from India. Both were lawyers, usually, not always. Special rapporteurs are lawyers because it's about rights. I'm not a lawyer, so forgive me if I tell something wrong. Next life, I would like to be a lawyer. It's very broad mandate, as you understand, and in this report also I was elaborating not only about rights of persons with psychosocial intellectual disabilities, but it's about right to mental health of everyone. My mandate is about right to physical and mental health of everyone. So, and working methods, mandated working methods are country missions. I have been already to almost all continents with country missions. Last one was Indonesia, next is Armenia. And thematic reports, once per year to Human Rights Council in Geneva, and then to General Assembly in New York, and many so-called communications when we write letters to governments about what we don't like, and they are confidential, but we always have a right to go public, and we often do so. So my predecessors developed this analytical framework. I will not elaborate on it. This is how we interpret right to health, including right to mental health. All these 10 elements are, for me, equally important, and if for some reasons some elements are missed or ignored, then things go wrong. My predecessors, Paul and Anand, had many good, powerful reports. And when I started 3 years ago, I was thinking what could be my contribution. Each rapporteur contributes with his or her own background, professional, even geographical. And in my first report, which was sort of vision report for my mandate, I told that I will address imbalances and power asymmetries. Of course, a big thing is SDGs, as you know, Sustainable Development Goals. I started from childhood. My first reports were on right to health in early childhood and adolescence. And I committed from the very beginning for mental health and also rights of persons with disabilities. At that moment when I started, there was no mandate, and Catalina joined a little bit later. And now, just 2 weeks ago, I presented to Human Rights Council this my report on right to mental health. Some words about my background, where I'm coming from. Coming from the let's say side which is so far not so friendly to human rights. Human rights of persons with psychosocial disability. It's medicine, it is psychiatry, and it is Central and Eastern Europe. I understand that all regions have unique problems. Some are common, some are specific. Central Eastern Europe for me is a very special region because it always had and has a lot of human and financial resources invested in mental health care, and they are invested in absolutely wrong way, so that they increase violations of human rights. And even with EU structural funds in so-called new countries, they are not any longer new, but just to understand that we're talking for those countries who joined the EU in 2004, 2007, still a lot of investments are going to renovate large psychiatric institutions. So this is one of first signals in my report that this is not about just let's ask for more money to mental health. In status quo situation globally, more money to mental health will create more more problems and not solutions, because the systems are not based on human rights-based approach, and especially in Central Eastern Europe, which has the highest number of institutionalized children and adults in the world. I just recommend one of new articles by many authors, including one of each of these countries. It was just recently, to see 8th of May in Lancet Psychiatry, about 25 years in investments, having mental health policies and services having failed in this region because of, as they say, non-transparent management. I would call this more understandable way. It's about corruption mainly in this field. And my next report to General Assembly, which I'm working now, is on corruption in healthcare system as a very serious threat to realization of physical and mental health. So now this report, I was working, thinking about these things from the beginning of my career, and I started as a psychiatrist many years ago, was still Soviet Union with the well-known Soviet School of Psychiatry, and I developed my own terminology even for these things. Now I have to adapt to UN terminology. But one thing which I highlighted in this report is, so to say, about diagnosis. I mean system diagnosis. If we want to make system work better, we first have to decide upon diagnosis, just a parallel with medicine. And in so-called global mental health movement, there is almost consensus that the challenge, the biggest challenge and obstacle is what is called global burden of diseases or global burden of disorders. So instead, I recommend to switch to global burden of obstacles, which is more serious challenges, and to invest so that these obstacles are removed. They hinder realization of right to physical and mental health, and not something which happened in, let's say, in the brain of person. So I identify three groups of global obstacles. First is severe medicalization of mental health and excessive use of biomedical model and biomedical interventions. I'm not against biomedical model, but as all good things, they become dangerous when they are overused and used without proper control. So biomedical model is heavily overused, mainly medications, but also diagnostic categories and some other interventions. Next obstacle is huge power asymmetries, especially between service providers and service users. They're much more pronounced to compare with general healthcare, general medicine, which more or less moved to partnership between doctors and patients, let's say. This did not happen in psychiatry. And the third one is biased use of evidence and what could be called the corruption of knowledge, when all stakeholders, general public, users of services, policymakers, medical students are misinformed actually about what is evidence-based and what is not. So, and this resulted in failure of all the status quo in mental health policies and services, and resulted in massive, widespread human rights violations in all settings: high income, middle income, low income, And this is totally unacceptable, and this is why from this diagnosis comes a recommendation not to decorate the system, not to feed her with further investments, but just to change it, to shift, to make a shift in policies and services. As you remember, in April there was, as each year, World Health Day. This year it was about depression. And on this occasion, but also in the report, I use this rhetorics metaphor maybe that from chemical imbalance, concepts based on chemical imbalance, which as you know now already are recognized as not scientifically valid anymore, to move to power imbalances, which are happening within mental health systems and around. And this has to do a lot with paternalistic context of relationships and patriarchal context of relationships in mental health care. The most hard talk, as you all know, is about implementation of the CRPD, and we all know that CRPD committee highlights the need to fully ban all non-consensual measures in psychiatry. My report highlights urgent need for shift to rights-compliant mental health policies and services, and the report tells that it recommends to take targeted, concrete measures to radically reduce medical coercion and facilitate the move towards an end to all forced psychiatric treatment and confinement. I imagine I would like to have to be part of process during the next 2-3 years. At least I have 3 years more to second term of my mandate. I'm finishing now first 3 years. We'll have 3 more. And I hope with this report to facilitate discussion and process and to find at least some champions among member states which will decide to move in implementing recommendations of this report and to move to remove obstacles and not anymore to be fixed on fixing disorders, so to say, which does not work. There's no secret that my report is partly, maybe not directly, addressed to most powerful group in this field. I think it's more powerful than policymakers. It's the group of psychiatric profession, and especially leadership of psychiatry. I do not think that it is a good way to demonize this group. If we want to reach a result, yes, now position of this professional group differs quite strongly from position of CRPD committee. It is based on 2 concepts, which I both of these concepts in the report I describe or declare as not as outdated, but they are valid. So in real life, is so-called dangerousness concept, yes, that people sometimes may be dangerous, and this is why psychiatry has a right and duty to deprive them of liberty. And another one is so-called medical necessity or therapeutic necessity, yes, that sometimes treatment is needed, but because these people do not understand, so psychiatrists apply force. So these two conventional wisdoms, let's say, are outdated. They are not supported by science. And my thinking, maybe naive, I don't know, we shall see, presents opportunity for psychiatry to be constructively engaged in this process. But of course, on very serious conditions. Some words about the general context. It's not that so dramatic, grim, but there is some retrogression going on globally with human rights, especially with sexual reproductive health and rights. And this is very much related with mental health, especially for for women, for LGBT people. We discuss this when we meet in Geneva. But I see the issue, the theme we discussed today, I see in the context of this retrogression going on globally, when human rights are seriously under attack globally. And I hear very often from high-level people that universal human rights principles are not valid anymore. Now it's up to culture of each country to decide which groups deserve human rights and which do not. So I think that it's quite a serious situation when people seem to forget why Universal Human Rights Declaration was born in 1948 and what happened before. Back to mental health, my recommendations are on all measures. Maybe one slight difference from many of my good friends, human rights advocates, users, and survivors, emphasize that I consider all other measures equally important as legal measures are. And if countries, as they are now, are reluctant to go legal measures, I mean to ban fully non-consensual measures, so this report tells then, until you wait and think, so just take and implement all other measures. Prioritize and mainstream alternatives, non-coercive alternatives, there are many. And then you will understand that you have to go also to make legal measures. So this is my understanding, that we should use all possible approaches, and this is not a compromise I'm doing. Thinking that member states are simply ignoring the recommendations. And there are many other recommendations in the report, how to move, how to try to address this impasse situation which is now with this recommendation of CRPD committee. I very much recommend and will recommend to states to seek technical assistance from the WHO Quality Rights Initiative. I think this is the best thing WHO has contributed so far to mental health and rights of persons with psychosocial disabilities. In the very end, I would like to just quote two things. How history is repeating, or I don't know how to tell this. You know this story 200 years ago, when discussion between state official Couthon and Pinel in dungeons. And Couthon tells to Pinel, now citizen, are you mad yourself to seek to enchain such beasts? Because you know they were behaving very not properly. To which Pinel replied, citizen, I am convinced that these madmen are so intractable only because they have been deprived of air and liberty. So, and after 200 years, I think, maybe not so much about air, but about liberty, we are still discussing. And another is from Jonathan Mann. He was pioneer in introducing human rights and health with a very powerful AIDS movement. And one of my wishes or dreams is that mental health movement reaches the same high level, political level of political will as it happened with AIDS, and it happened because of human rights have been taken seriously in AIDS movement. So I wish that the same serious approach stakeholders take in mental health. If they really want to move with mental health seriously, human rights-based approach is a crucial one. So thank you very much.